Okay, so we have made it to the last panel of the day. I know many of you have been here really having that elevated conversation we look forward to each year at the National Minority Equality Forum. I'm excited to be back today with you. My name is Shyrea Thompson. I'm the the Strategic Director of, it's a new title, a Strategic Director for Informative Partnerships at Susan G. Komen. I'd like to invite you all to join us as we have a conversation for grown folk, a discussion on the health of mature adults. We know that this is a conversation that truly matters because as we face the interventions and the innovations that are available in communities across our country, we know that we are living longer and more fuller lives. So today we're going to have a conversation with some stripped down topics as well, as Mia has encouraged us to have. We'd like to appreciate the work that each of you have done and thank the Congressional Black Caucus Health Braintrust for this opportunity to have this dialogue. And also, if you'd like to follow along and share with Congresswoman Kelly on her Facebook page at Rep. Robin Kelly, hashtag CBC Health Braintrust. So we're gonna go ahead and get started by introducing our panelists. Today we have the distinguished Dr. Kisha Davis of Family Medicine and Medical Director of the Casey Health Institute. We have Dr. Kimberley Perkins-Davis, Chair and Program Director of Oral Surgery Department at Meharry Medical College. Mr. Prentice Stovall Jr. of the Global Brand Leader Insulin Franchise for Eli Lilly and Company. And Dr. John Bonhomme, founder of the National Black Men's Health Network and member of the Men's Health Network Board of Directors. I know many of us think about aging. We may be in that journey in life, or we may find ourselves caring or thinking about those next steps. In preparing for today's panel, I thought about some of the members of my family. I had my grandmother here last week as we were preparing, and really looking at what do those next steps look like in healthcare, but also making sure that we can really champion health equity for our communities. Maya Angelou once said, at 50, I began to know who I was. It was like waking up to myself. I think many of us can think about that quote and see ourselves in that quote, or it might be something that you are living your own life by. Our panel today is going to do a deeper dive into really looking at what are those steps that we need to take to achieve health equity for maturing adults. And we're going to start by learning more about the perspectives that each of our panelists bring. So Dr. Kisha, if you could share more with us about your insight and really that journey that you've been on in your adult mature care age.
Sure. So I just would like to take a moment to say thank you for having me here. Thank you to the CBC Braintrust, the National Minority Equality Forum. I'm a former 40 Under 40 winner, and so it's really an honor to be back here on the stage with these distinguished folks. So I'm a family medicine physician, as Shyrea mentioned, and I really went into family medicine to take care of women and babies. And the funny thing is, life takes you on a funny journey, and what I enjoy now most is caring for my seniors because of a strange turn of events. And when my health center opened and what was going on in the community, we acquired a large number of senior citizens. And some days my average age is 70 for the patients that I see. And I really, really enjoy taking care of what I call my life experienced folks. I have been really lucky. I had all 4 of my grandparents who lived into their 80s. And I have one remaining grandmother who, God willing, will pass into 100 years this coming June. And her social calendar is busier than mine. I was supposed to take her somewhere this Saturday. She was already gone all day. And, so I've had the blessing of having examples of really what healthy aging looks like and what healthy aging can be. And I bring that perspective to my patients. I think it's really important in my role as a family physician is not just to treat someone's illness, but help them to thrive at every stage of their life, whether that be young, teenager, middle age, and into the older years, and helping them thrive at every stage of their life. And when the time comes, helping folks transition peacefully over to the next side. So, I think what I really hope to share with all of you today is really some thoughts on how to live well, how to thrive, how to really make the most of all of your years.
It's very well said. I think we all want to do that. Dr. Kimberley, in preparing for today's time together, you brought a lot of insight to this conversation. We'd love to hear what has shaped kind of that vision for you with caring for adults.
So for me, I had a 26-year history in the United States Army, and I then came back to my alma mater to teach the dental students and residents at Meharry Medical College as the director of the oral and maxillofacial surgery program. But in that, our purpose is to help the students and the residents understand that oftentimes people overlook dentistry. And I know that was mentioned in some of the earlier panels, and I actually appreciate that because we get to see a lot of patients, and particularly the elderly patients or the aging patients, we get to see them a lot of times in place of or before a lot of their primary care physicians do. And as we age, a lot of the comorbidities that we may have present themselves in the mouth. And what we try to stress to the students and to the residents that we teach is that it's very important that we're aware of how these disease processes present themselves in the mouth, and that it's important for not only us as dental providers, but other healthcare providers, other than physicians, be aware of how these processes present themselves in the mouth. And it's important as we age that we maintain a healthy lifestyle, a healthy mouth, and again, be aware of all of the different manifestations that can present in the mouth.
We know oral health is certainly important, and working in teams to improve patient care is critical. Mr. Stovall, in your role at Eli Lilly, you work in teams, and as we were talking, really leading into today, you talked about some of your history coming from across the country to join us here. Can you share with us that perspective that you brought with you today to this panel?
Oh, absolutely. Well, thank you for blessing me with the title of doctor as well.
Don't worry, I was JD yesterday.
No, but well, first and foremost, thank you so much. Very humbled and honored to be a part of this panel, and it's been great to hear the conversations as it relates to health equity or health equality, and the conversations have been incredibly rich and deep, but it's also very clear that there's work to do, so it's been great to just hear those perspectives. That being said, again, I'm the global brand leader for our mealtime insulins brands at Lilly. So again, I'm responsible for the commercialization or the bringing products to market for not only our existing brands at Lilly, but also our future insulin brands. I also am the president of the African American Network, which is the largest employee resource group at Lilly amongst, I believe, 10 or 11. And that puts me in a great position to do one of threefold. One, be a strong advocate for African Americans as it relates to diabetes. Two, sitting as the president of the African American Network, advocate for the lived experience of African Americans at Lilly. And then three, be an advocate for the patients that we serve at Lilly who happen to be African American. So it gives me a great perspective on health equality, in particular for the African American population. That being said, I sit in the pharmaceutical industry. I've been a patient in certain circumstances, but also a caregiver. And that's put me, I feel like I've sat in the front seat, rather, of the progress that we've made in healthcare. We've made some significant advancement, in particular in diabetes. I mean, you think about the number of classes of drugs that we have in this space. It's gone for a few to many. The Minority Physicians Alliance, which I believe was announced yesterday, I think that's another great example of partnership and how that leads to better health care for African Americans and minorities in general. But also I want to speak to the progress that we've made on insulins. Lilly, since 1923, commercialized the first insulin in mass production. And since then, we've improved our insulins. I mean, it's gone from animal insulin from pigs and cows to human insulin, to ultimately insulin that is delivered through pre-filled pens and now pumps in a connected world. So we've made progress significantly among the past 90 some plus years for insulin. And I often tell the story of my grandmother. 30 some odd years ago, I remember sitting on the bed with her as a young child in Gary, Indiana, where my family is from. And I remember her pulling up her gown and showing her scarred thigh and injecting herself with insulin multiple times a day. And I remember her sharing with me that, yes, Prentice, I got a little bit of sugar in my blood. And as a young child, I thought that was actually quite interesting. Nothing wrong with a little sugar in my blood, but what I didn't quite understand at that time was that she was taking insulin to save her life and to keep her alive. And as a person with diabetes, I had no idea that this disease was eroding her from the inside out. So you fast forward 30 years now, I certainly appreciate that moment and the advances that we've made in the diabetes space. But that being said, although we've made progress, there are certainly some opportunities and frustrations, if you will, as well. I mean, certainly I've heard diabetes literacy as a problem that we need to fix. Affordability is something that is always a question on the table. We have short-term solutions in place, but we need long-term sustainable solutions. And I think the theme that I heard was partnership and how that is critical for us to move the needle on health disparity. So I'm looking forward to sharing my perspective over the next hour or so. Thank you.
Well, thank you again. Dr. John, you are here, and you mentioned that you certainly would like the opportunity to share your journey, how you got to this seat, and that path that you took in your career. And we're excited for the opportunity to learn more about that perspective and then also the work that you do each day. So if you could speak to that journey and your work.
Well, first of all, thank you for having me here. I started out in categorical internal medicine at Grady Hospital, and something struck me during my internship was how closely related the diseases that people were presenting with were to their lifestyles. I remember a woman of about 45 years of age having heart attacks, and I asked about her diet. It couldn't have been more cholesterol, full, bacon and eggs for breakfast, hamburgers for lunch, pork chops for dinner. One guy was smoking 3 packs a day, and I showed him an x-ray that showed that he had a lung cancer, and the first thing he said was, "Oh my God, I need a cigarette."
Behaviors.
Then I had a auto mechanic who had leukemia, and I found out later that gasoline contains benzene, and chronic exposure to gasoline, whether it's on your skin or in fumes, can cause leukemias and lymphomas and other blood-related cancers. An elderly man in Middle Georgia asked me, he said, "You're a doctor, how come my hand hurts me so?" And he had done hard labor all his life. You could have struck a match in his hand. As a matter of fact, he had pain all over the joints on the right side of his body where he was lifting. And it became clear to me, I took a different view of disease because in medical school, it was like, this person is coming to you with a heart attack, or this person is coming to you with angina, or this person is coming to you with emphysema. I see the diseases now, most of the time, are like the leaves on a tree, but there was a trunk and roots that brought it there before those diseases blossomed. So between 80 and 90% of the time, the diseases that we get are related to the way that we live. So for that reason, I kind of switched gears. I got an MPH and went into preventive medicine. In 1987, I got together with a group of people, including a Vietnam veteran who is now deceased. But we founded an organization called the National Black Men's Health Network because nationally, in the mid-1980s, African-American men weren't living long enough to collect Medicare or Social Security. And we wanted to try to publicize what was going on and maybe get some intervention. So our first project was to do AIDS prevention education in men's homeless shelters. After about 6 months, we realized that that was kind of ridiculous. If we didn't educate the women, that would endanger the men. And if we didn't educate the men, that would endanger the women. So I developed a philosophy that we need to address the health of the whole community. We need to address women's health, men's health, minority health, and children's health as co-equal partners, and that the failure to address any of those groups would prevent us from optimizing the health outcomes in the other groups, because let's face it, we live together, we interact. There's a tremendous amount of literature on how, for instance, a woman being widowed, her death rate goes up. She's more likely to go into poverty than if she was divorced. So the point is that the health of one group affects the health of other groups. We became integrated with the Men's Health Network in Washington, D.C., which wasn't as focused specifically on minority men, but men in general. But we strongly believe that it's important to address the health of the whole community, and especially to look at the role of lifestyle and life choices and things that we do and that determine, whether or not we get sick. And as I said before, that's why I like the model presented in dentistry so much, is because you come in every 6 months to get your teeth looked at, whether you feel anything or not. You don't have to wait until there's pain or there's disease. We try to nip things in the bud. So we developed a philosophy that we wanted to address the health of the whole community. We feel as though, in some ways, men's health hasn't received the amount of attention that it deserves. Like, for instance, prostate cancer has a prevalence and a mortality rate similar to breast cancer, but it doesn't get nearly as much attention. How many people in the audience have heard somebody say prostrate cancer? Yeah, so that's the basic issue. People don't know about it, and people don't know enough about it. They did a convenience sample of asking men on the street, what does the prostate gland do, where is it located, and about half of them couldn't answer. And one of the weirdest things is when we do prostate screenings for men, we've had women get angry at us saying, why are you doing this only for the men? People don't even know. A lot of the public doesn't even know which gender the gland belongs to. So we got a lot of work to do, let's put it that way.
That was a really strong opening, and you talked about that holistic approach and really looking at how we're treating people and reaching them where they live, work, play, and pray. Dr. Kisha, in your work, you do take that holistic approach. Can you talk more about why it's important to look at the holistic options in medical care for aging populations?
Sure, and I thank you, Dr. John, for bringing that up, because it's so important when you're having conversations with patients or even family and friends and those seniors in your lives to think about them more than just the medications. As we get older, there seems to be more and more medicines in the medicine cabinet, and it's easy to get caught up in health, thinking that health is, did they take their medicines as they were supposed to? What's the blood pressure number? What's the diabetes number? What's your A1C? And we all know that we are much more than our cholesterol numbers and what medicines are in the medicine cabinet. And so really, at my office and just kind of my approach to thinking about patients is really thinking about the four pillars of wellness. And so trying to help people think about moving more, eating well, stressing less, and connecting deeply. And so when you think about moving more, really at any stage in your life, we should be moving. You should be active. My almost 100-year-old grandmother still does her exercises every day. And if you haven't heard anything about Ruth Bader Ginsburg, she is too. So, really staying active to the extent that you're able, pushing through the pain a little bit, not too much, because we know that our seniors underestimate their pain, but really that helps stay active. What we know about walking, just a simple 30-minute walk most days of the week, is that not only does it help with weight loss and help with blood pressure and help lower blood sugar and help decrease stress, we also know that that exercise is one of the main things that's been shown to prevent or delay Alzheimer's disease. More than the crossword puzzles, more than the fish oil that you're taking, more than the B12, it's really staying active and getting that movement that really helps the mind stay active. When we think about eating well, many times as we get older, the world gets smaller and might be harder to get to the grocery store. Folks may cut down to just 2 meals a day to save money. And so you want to make sure that you're checking in on folks and make sure that they're getting the nutrients that they need. Vitamins are great, but they don't replace real food. And so vitamins are a substitute for eating real food. Your body absorbs things the best when it's getting it from food. So geritol is great, but a salad with some kale is even better. The other thing to really think about is stressing less. And it's hard these days, especially in the DC area. It seems like, since the last election, we are just bombarded every day with the new atrocity, a new trauma, a new video, a new what happened in the White House. And sometimes you really just have to take a step back and breathe, and you need to encourage older folks to do that who may be sitting at home watching TV and seeing all of this stuff come through every day, every minute breaking news. To really step back and think about the stress that's in our life and how it's affecting us, how it's affecting blood pressure, how it's affecting blood sugar, and how it can potentially be getting in the way of thriving. And then the last thing is really connecting deeply. And so one of the things that we know is that people who are connected do better. And this is in humans, but it has even shown up in studies in rabbits, that the rabbits who all had the same heart disease, and they were all, these were the sick rabbits. They were genetically engineered to be sick, and you expected them to die. And this one group of rabbits wasn't dying as fast as the other group of rabbits. And they looked into why they weren't dying. Well, come to find out, the woman who came to clean the cages, she wasn't very tall, so she could only get to the cages on the bottom. And so she cleaned the cages for those rabbits, and she would take them out, and she would pet them, and she would talk to them, and she would play with them, and then she would put them back. And the rabbits on the higher shelves, the cleaning company would just come clean the cages, take them out, and put them back. Those rabbits that had that touch, that attention, live longer. If it's true for rabbits, we know that it's true for us. When we look at seniors that have a community around them, of family, friends, neighbors who are looking out for them, we know that it makes a huge difference in their life. And the other thing that you start to lose sometimes as you get older is that purpose. You sometimes see folks after they retire feel like, well, why am I still here? What am I doing here? And I think it's really important for helping seniors to connect back with their purpose and why they're here. I had a woman just yesterday who I was seeing on hospice. And, I told her, I said, every day that you're still here is because God has a purpose for you. And you may not feel it, but there's a reason that you're waking up each morning, and it's your job to help figure out whose life you're impacting just by being here and what your example is going to be. So, helping seniors realize that you're here for a reason, and they need to spread that.
It's beautiful. Dr. Kimberley, you shared a little overlapping perspective when you talked about the interaction that you get to have through oral health with your patients, that extra touch and that extra care that you're able to give. Can you talk more about why that's important and really some of the barriers that patients also often face around insurance and access?
Sure. So it's important as we age. As I mentioned earlier, oral health is important. Once we lose our teeth, whether it's from periodontal disease, from dental decay, cavities, you can't eat, you can't remain healthy. And so that's important. Also, again, access to care. People may have to choose. So choose whether they can go see the dentist, choose whether they can go see the physician, whether they can buy their medication. And oftentimes, dental falls by the wayside. So for those rare opportunities that we actually get to see the provider, I figured that it's an honor. And so that we need to do what we can to teach health promotion, education, preventative measures, and put that out there. As far as those seniors that have cognitive issues, whether it's from Alzheimer's disease, if they've had a stroke, if they've got Parkinson's disease, anything that keeps them from physically being able to keep their mouth clean, then you're looking at, as you've mentioned before, who's caring for them. So with patients with cognitive issues, they can't remember to brush their teeth. So when their family members are there with them, oftentimes there are other pressing medical issues that they're worried about, and their teeth are the last things that they worry about. But then it's making people aware that that is important too, because again, if they lose their teeth, they cannot eat, and their bodies will not remain healthy. So, and the same goes true with patients that may have had a stroke and now they may be bound to a hospital bed. So who's coming in to look after them? We would like to believe that in the nursing home that they may be in, or if they're being cared for by a family member, that somebody is going in and giving them proper oral care, but that may not always be true. So who is going in to make sure that they're receiving the proper oral care that they need to? When you go back to access to care, Medicare doesn't always cover dental benefits. Medicare Advantage might sometimes cover dental benefits, but then that's according to what state you live in. And then if there's a senior that is able to get Medicaid, those are few and far between because sometimes their retirement from whatever occupation they had may put them in a situation where they make too much money to be able to get Medicaid, and Medicaid would have paid for these dental benefits. And so then you find yourself in a situation where, again, they can't afford their dental benefits, so they're forced to choose. So.
Now, you talked about that decision that we have to make or that you see your patients making. Would you say in communities of color that there's any different or any best practices that you've seen work?
As far as having the patients come and receive care?
Yes, around access for oral.
With a lot of communities of color, I see that you have providers that are willing to help, whether it's with reduced fees, whether it's with free dental care day or the Mission of Mercy. I'm not trying to plug a specific organization, but whether it's with a volunteer organization that's willing to offer free health care. Our school, for instance, offers like a free dental day, and they'll put it out to the community so anybody who comes can receive dental care for that day. I think that communities do that, but I don't want to limit it to communities of color because I know that a lot of communities do offer that for their underserved population. So.
That's really well put. Well, Dr. Jean, I know that you talked a little bit about your experience and how you've gotten on this journey and the founding of the Men's Health Network work. Would you be able to talk a little bit more about that special dynamic between the self-care relationship and then also the relationship that men have with their loved ones? I think when you think about maturing and aging adults, often those are topics that we don't talk about, particularly around men, and we'd love to hear your thoughts around that.
I think that one of the issues that undermines men's health is that what we talked about, first of all, most people talk about the financing of health. People ask me why I became a doctor, and I often tell them so I could doggone afford one. But the thing about it is healthcare is expensive, but I think that one of the main things that we use to get men into healthcare, which is often a challenge, is family. Your relationship with others, because a lot of the times when you try to tell a man that he needs to take a medicine at such and such a time with or without food, and he looks at you like a deer in the headlights, sometimes it's the wife or the other family members. It could be siblings, it could be children, it could be parents, or something, can often help the person understand that. So the relationships with other people are a big part of what makes us healthy. Men seem to have an aversion in this culture to going to the doctor because they feel like it's weak, or they've been taught as men to be stoic, to just soldier pain. Like when a boy's 8 years old and he skins his knee, they tell him brave boys don't cry. When he's 15 and gets hurt playing football, they say take one for the team. So when he's 50 and playing and having chest pain, he says, oh, that's just indigestion, because he's been taught all his life to minimize the signals of his body. So men will sometimes not do things for themselves, but they will do things as part of a group. Like we have an annual health fair for men, and if you make it a group event, like going to a football game, or have the family bring the person to the healthcare event, they'll do it as part of a team. Men are more motivated in that way. I think that isolation among men is part of the reason why I think that men have some of the problems that they do, because number one, when you're isolated from other people, you don't have the sources of information. You don't have that reflection from other people. So somebody can tell you, hey, you really don't look well today. And you don't have that feedback from other people. So our relationships with other people are important. But the other people can also assist the man, in helping him to take care of himself.
Those relationships, again, we hear that as a theme. Mr. Prentice, you at Eli Lilly are working to create access to insulin and other treatment. And when you talked about that cost, again, that joke you made about why you became a doctor, it's so true. If we can't access the innovations, it's going to impact our outcomes. So can you talk more about what Eli Lilly is doing to create access to those insulin programs?
Oh, absolutely. Well, diabetes, I think sometimes we don't fully appreciate the journey that a person with diabetes goes through. The first time that they're put on insulin and take it out of the package and inject it for the first time can be incredibly challenging. The first time that a patient moves from one type of insulin to another type of insulin can be incredibly challenging. The times where they have to manage their meals in order to prepare to take insulin or take insulin prior to a meal can be quite challenging and jarring. And as stakeholders, I think collectively sometimes we don't fully appreciate that. But the partnerships that hopefully are forged within this room can hopefully advance the needle or move the needle as it relates to ensuring that we are providing the right experience for people diagnosed with diabetes and ensuring that these same people have access to the medications. That being said, Lilly has been in this arena for quite some time, since 1923, and we've moved the needle as it relates to insulin, starting from a large needle, which is quite wide, to something that is now in pre-filled pens and now in pump technology. And that advancement, certainly, there's a cost associated with the movement in technology. That being said, Lilly does firmly believe that not only do we have to deeply understand the patient's experience with diabetes, but the model has to be designed to ensure that people with diabetes, get access to those same medications. So there are three things that we're doing, I would say largely to support that move. One, we are working closely with faith-based organizations. So one in particular, Church of God in Christ, and another church that has about 7 million members in total in the U.S., African-American-based organizations. And we are partnering with those groups to ensure that the education is there, that there is strong information on ensuring that people with diabetes know what it means to have diabetes, to ensure that people with diabetes knows what it means to prevent the progression, and to ensure that people with diabetes understand the importance of remaining on therapy as prescribed. So it's partnering with those faith-based organizations is the first step in the process. Second is ensuring that we are supporting legislation to provide patients with access to those medications, insulins in particular. For example, we are now a part of the Smarter Health Care Coalition, which I believe is connected to the Chronic Disease Management Act of 2018. And that act is a partnership amongst stakeholders, so regulators, policymakers, payers, healthcare professionals, to ensure that we are charged with providing access to medications through insurance plans and other means of patients receiving access to drugs. Third is ensuring that we have discount programs in place to reduce the burden of patients who might not have coverage. What we know about the U.S. population is approximately 90% of people have some form of coverage which allows for them to afford the medications of chronic illness. But there are 10% of U.S. citizens or Americans who do not have that level of coverage, those that are just completely uninsured, those that are on Medicare Part D but have hit that coverage gap or that donut hole, and the other population that are in high deductible health plans. So we've built short-term solutions to ensure that 10% in particular has access to medications, so copay programs and other types of programs that reduce the cost at the point of sale at the pharmacy. There is much more work to do. Those are some short-term solutions. But again, as stakeholders in this room, I would charge us with partnering and creating long-term solutions so patients, in particular with those in diabetes, have access to care and medicines.
Partnership, 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 partnership. That is truly important. And it's exciting, I think, to hear how you each have looked at it in your own perspective, in your own work. In one area of development with adult health, Dr. Kisha, I know you work and care for patients. And when you think about kind of that individual perspective, we know sexual health is really important to talk about and tackle. We know that pharmaceutical advancements have really kind of put that at the forefront as well. Can you talk more about that?
Sure. People don't stop having sex when they turn 50 or 60 or 70 or 80 or 90. But you won't know if you don't ask, right? And so, I think it's important, for me as a doc, we have something that Medicare covers now called the annual wellness visit, and it's a part of the question, asking people about their sexual health, about any sexual dysfunction, any problems, any pain. And it's one of those things that we tend to minimize and forget and don't want to address in the older populations, but older people are allowed to have a sexually health life just like everybody else, right? And you want them to as part of their, being able to thrive at every stage. But just like with younger people, there are risks, right? So I tell my older folks who are sexually active that they need to get their HIV test just like everybody else. We know that that's one of the areas where HIV rates still continue to rise. I had a patient over 50 who I recently diagnosed with HIV. She had no idea. She actually hadn't been sexually active in the last few years, and if it wasn't part of the standard panel that I do for everybody, we probably wouldn't know. And so again, that's one of the things that you want to keep asking folks. Also, folks in nursing homes, you want to be asking them about sexual activity. If you look around, there's a lot of women, there's not a lot of men. There's sometimes an imbalance there, but you also want to be asking in terms of dementia and consent and thinking about those issues as well. All of the commercials about Viagra and Cialis and Levitra have actually made that conversation, I think, a little bit easier. When Bob Dole is sitting on the couch in a commercial talking about the little blue pill, it makes it a little bit easier to have that conversation with your doctor. And I think that has opened a gateway to really help people, enjoy their lives in every phase of it. So I think it's something that, as a physician, it's important for me to ask about. And as a family member or a spouse of someone who's older, and supporting them and recognizing that that is a part of the life experience.
We know this is really important, and I think as we open up for Q&A, we're going to first lead with one open question, and then if you have any questions, we do have mics in the audience. We want to elevate that conversation, and you mentioned elevating the conversation around sexual health, but when you really think about the purpose why we're here at this conference around health equity, can each of you, as we segue, just speak to what health equity is and looking like for mature adults and how we can each elevate that?
Sure. We talked on the panel earlier a lot about the trauma that young people are going through, and Black Lives Matter and all of the police assaults. Our seniors went through that too, right? And so, recognizing that that is a part of their life experience and giving them the time and opportunity to validate that. So that's another thing that I think we don't talk about in the senior population is the mental health aspect. And so there's a health equity piece there that getting older is not just about your physical body, and it's not just about your mind in terms of forgetfulness, but there's a piece there in terms of depression and anxiety and past traumas that they have buried and buried and buried for many years. I had a patient in her 70s who finally, for the first time, admitted that her husband had been abusing her for the last 50 years and was finally seeking counseling after 50 years of being married to this man. And so she had about 2 good years of, she was in counseling in a good space, not depressed, until he developed dementia, and then all of those behaviors came back again. And so again, I think it's really thinking about all aspects of people, not just their physical, the nutrition, the mental health, those interactions that really help to get at some of that health equity and health disparity.
Dr. Kimberley?
For me, it would be about access to care for everybody, and for those that are in a position to give back, to give back. So however that means for them, I think that's the best way I could put it.
That's very well put. Mr. Prentice?
Sure, I would say taking off from a helipad would be my way of phrasing it. Sometimes we often wait for the runway to be completely smooth with no bumps to take off on our airplane, but we have a lot of information. We've been talking about this for quite some time, so it's now time to just use what we have and take off from the helipad and see what progress we can make today. To speak to the African American population in diabetes, 13% prevalence. When you compare that to other populations, we are overly represented, but I think to the comment yesterday, underrepresented in clinical trials. 50% of people with diabetes are not in control of their blood sugar. We got to make a move in that space. And, in the African American population, it's not just a little bit of sugar. I mean, if I could go back and tell my grandmother or my grandma that, I would tell her that, but there's work to do in ensuring that there is a level of diabetes literacy to move this needle. So taking off from the helipad would be my charge for us.
That is very well put. Yesterday I shared, one of my mentors said, we have been admiring the problem for too long. And I think we all know that we have been doing this work for more than 30 years, this information, this research. We know what needs to be done. It's really about making those next steps into action. So I like that helipad. I'm adding that to the list. Dr. John?
Health equity is a very big word, and so there's a lot of different, everything that's been said so far speaks to health equity. For me, 2 ingredients that I would add is, number one, I think we need to overcome the fragmentation in our healthcare system, because dentistry is in one place, mental health is in another, medicine and surgery are dealing with each other, but kind of in a rivalry, and I think that it causes people to fall between the cracks. I remember when I was the director of a community mental health center, they gave me a woman who they told me was schizophrenic. I did a mental status exam on her, and the only thing was wrong was her short-term memory. And I asked them, did you test her for syphilis? Did you test her for B12? They did a spinal tap. She had neurosyphilis, and they were calling her. But the psychiatrists don't want to deal with somebody who they think is medically ill. The internists don't want to deal with somebody who is acting crazy. So we need to put the healthcare system together to integrate it. And I think that's part of the problem. The other thing that I think we would need to do to achieve health equity is to make sure that the public is well educated about health issues, because when you have a person who's doing manual labor, doesn't have the same issues as a woman who has a family history of breast cancer, who has the genes for breast cancer. People need to know what pertains to them, what their family history is, what they need to watch for, what their lifestyle factors might place them at risk for, et cetera, et cetera. I always want to try to make sure that a person who comes to me for healthcare really understands what's going on. You can even explain to somebody with a second-grade education, you can explain to them health issues. Like if a person had a second-grade education, I was talking to them about cancer, I would describe it like weeds in a garden. If you don't get it out, it will spread all over and kill the entire garden. So you need to get it out while it's small. So the point is, you can make analogies to make anybody understand what's going on with them. And that does 2 things. It improves compliance, because when the patient is educated, understands why you're doing why do I have to take these pills and spend this money and I don't feel any different, or I'm having side effects. It improves compliance, but also a health-educated public could put more pressure on funding sources to meet their needs, because they know what's going on. So I think that health education, health literacy, and also overcoming the fragmentation and the gaps in the healthcare system would be a big step toward health equity.
Very well put. Are we having a conversation with our patients, or are we talking at them? We want to have a conversation with each of you in the room. I'm not sure if there were any questions. The mics are on either side, and as we open the floor, I want to just shift to make sure that we can include time to have our one tip that you may leave as a call to action for folks when they leave here today to help achieve health equity for mature adults. And then we'll actually open up for Q&A. So we'll just go through the line.
So I'll just highlight the 4 pillars again. So move more, eat well, stress less, connect deeply, and I will add one charge to that, which is get your flu shot.
So mine is make sure you go to the dentist. Get your health exam.
For me, again, it's take off. I mean, we should all be walking away with one relationship that we could forge moving forward. So take off from the helipad would be mine.
For me, it would be learn to take care of your body. It's the only place you got to live.
That is so true. That science is a long way away. Thank you. So we're going to open up to the floor for questions. We'll take this gentleman here.
Great discussion. My question is, as we age, there's more pressure put on the family members to provide as caregivers for the aging population. What are some resources or best practices? Because there's not enough for minority groups to have that conversation about taking care of their parents or grandparents. There's a lot of pressure where it looks like we almost failed if we put our parents in a nursing home or ask for help. It's, as the youngest son, I'm responsible for my parents and I need to be their primary caregiver 24/7, but I should be able to feel comfortable to reach out or find sources that could help me. So what are your suggestions in terms of helping people know that you don't have to do it on your own to be a caregiver for your own parent? And what are some best practices that you can highlight that you may be aware of?
That's a great question. I facilitate so many fights in my office. It was between moms and their teenage daughters, and now it's between elder parents and their grown children about who's the parent in the situation. So, when you think about seniors who may now be living with their children and have been used to being independent and now don't necessarily get to control what they eat or where they go or what they get to do, it's a setup for tension. And I think especially in communities of color, there is this stigma or sense that I'm not a good child if I put my parent in a nursing home. We're getting past that, but there is a lot of that, of feeling like I need to do it all on my own and I cannot ask for help. And I think that those are some things as a community that we really need to start moving past in terms of looking outside for resources to help support you. When thinking about things like, if the family is, if that older parent is going to come move in with the family, what are additional supports that can be there to help? Is there outside help? Is there adult daycare? Are there other seniors in the neighborhood that you can help facilitate where they can get together and interact? And I think for that sandwich generation who may be taking care of an older parent and younger children, looking out for themselves. They are frayed and burned at both ends, and really thinking about their own health. We've all heard put your mask on first. That if they want to be there to help that parent, they really need to be there for themselves too. And I think that's something that is really hard, especially in communities of color, to take a moment and care for yourself in the midst of caring for other folks. In terms of thinking about resources, a lot of local communities, Department of Aging has good resources. I'm in Montgomery County, Maryland, just outside of DC. We have many social service agencies that have outreach for seniors and ways to access it. But churches have a lot. Faith communities really are starting to develop more resources, both for the older person, but also for the caregiver.
The next question?
Yes, thank you all. Great discussion. I'm a geriatrician, and a problem that I have, and perhaps you guys can help me think about it, is we always talk about the social determinants, and in particular with our elder population, we have a problem with appropriate housing. Mm-hmm. I'm not talking about long-term care facilities, but housing in general, and access to transportation, public affordable transportation. So I'm curious to know what you all are finding in your communities. I'm in Albuquerque, New Mexico. We have issues. How about you all?
It's an excellent question. One of the number one barriers to care.
So in the Nashville, Tennessee area, what I've noticed is that the over 55 communities are popping up, but they may be a little cost prohibitive. And if you're not able to afford the loan, or if you're in a situation where you've got to sell your house before you can purchase another home, then you're told, well, no, you can't do this. And then there's the transportation issue that you bring up. So it's interesting because I'm in a sandwich generation type situation. And so in looking for situations for my parents, we've been looking at, well, what's available. And I've been faced with some of those things. And so if you are in a situation where you don't have means, or if you do have means, you know, it's very unfortunate for some people.
Would anyone else like to address the question as well?
I can just say in my community that that's a huge problem as well. The lack of access to housing, I know the waiting lists for housing, especially for seniors, is months to years long. And then transportation to get there is a huge problem. I think one of the solutions to that is it doesn't happen in the exam room, it doesn't happen in the dentist chair. It's really advocating for those public policies that help change the system and that are addressing the social determinants of health. And when communities are being planned, that they are really thinking about everyone that's part of that community. We also have the same, you know, these over 55 communities that are cost prohibitive. And so city planners and community planners really need to be thinking about access for housing for all in the area.
Exactly.
Also may help to access some of the groups, support groups that they may have for specific diseases and for caregivers, because, for instance, if it's a transportation problem, then maybe you may meet somebody in the group that would be willing to transport a group of people or something of that nature. So, you know, you may be able to find some resources through there, because everybody's in the same boat being stressed, so I think that some people would be willing to share. And the mention of churches before, sometimes faith-based communities will be willing to help you with that.
Very true. In addition to that, in our work with breast cancer, there are a number of hotlines that you can also reach out to. Susan G. Komen has one that we support for breast cancer patients. The Patient Advocate Foundation is also here. I'm not sure if Shanta's in the room, but there are a number of resources in our community that if you need help now, today, and making sure that we can close that barrier is important, because if you can't get to care, you're not going to avail yourself of it. So there's access, but there's also utilization that we really need to tackle. And I see you're back at the mic.
I just want to say, these are well people. These are not diseased people.
Right.
Aging is not an illness or disease.
Right. Yes.
But in order to promote health and well-being, they still need these things.
And we completely agree, because staying active is part of that full life. I wanted to make sure that I highlighted the reference to chronic diseases as well. So I wanted to make sure that we could get to the other two questions, and then Dr. John also wanted to speak a little bit to a new opportunity that we've been seeing around programs of patient and companion care as well. So I think there were two questions, or if you wanted to go, ma'am?
Yes, just to follow up on the first question, personally, I had to be the caregiver for my grandmother, and at the time, I was actually in college, so I had to stop and take care of her. When me and her got to the point where I wasn't able to care for her at home and placed her in a nursing home, she was really upset about it, but she understood, like, I couldn't do it by myself. My grandmother didn't speak English. When we went to the nursing home and the facility that was able to care for her, they told me, like, don't worry, we'll take care of your grandmother. We have language access for her. She won't feel like she's not being heard. However, doing my own personal, just looking into it, talking to my grandmother, talking to a couple of the residents there at that facility, there was a lot of burnout in terms of the caregiver, the providers, the nurses, the physical therapists, et cetera. And I realized that if I wasn't there 24/7 with her, that she wouldn't get the care that she needed to get, because there's a lot of people in those situations that don't have someone there for them to run to be like, hey, the bell has been ringing for like 10 minutes and this person is spoiled. You need to help them. And I feel like it's easier when you can say, like, don't worry, everything's going to be okay at this nursing home or at this facility. She'll be taken care of, or he'll be taken care of. But then in reality, the burnouts, the long hours, it can be really hard and frustrating on the staff. So just possibly could you speak a little bit on something like that, where people may feel comfortable to finally get to that facility, but then they're not receiving that care that they were promised?
Would you like to take it, Dr. Kisha?
You know, I think that's a powerful story. And I think, just you having lived through that is a reminder that even when, at some point, you're trusting this environment and this community that you're putting your loved one in, and that can be really hard. And, feeling like you're doing everything that you can and trying to do the best for them and by them, and still sometimes feels like you're up against a wall. And, that's where, getting the supports, calling on the community, having a rotation of people to come visit, things like that are helpful, but there's no good answers. Yeah.
This gentleman.
Thank you. Good afternoon. My name is Nestor Ramirez. I'm a retired neonatologist from Champaign, Illinois. And being one of the senior folk, I want to give you guys a word of advice. First of all, take care of yourselves. If you don't take care of yourselves, who the hell is going to take care of your family and your friends and your patients? The other one is, I wake up every morning and I look at some of the wooden tokens that I pass out to everybody. Some of them got it, some of them didn't. And it just says that I'm always A cubed and E squared. Alive, alert, awake, enthusiastic, and energetic. Thank you.
That's great. EQ square.
Hi, Ernestine Willis, a pediatrician at the Medical College of Wisconsin, but in my personal life, many days I feel like a geriatrician because I have family members and in-laws who are in their 90s and 80s and trying to deal with the health condition, and the list of conditions is 20 lists long. But what I wanted to get the panel to speak to is that while we have the complexity of the aging process, the health literacy status of senior citizens began to dwindle. The complexity of our health system gets more complicated, whether you're filling out Medicare forms, et cetera, et cetera. So I wanted to get some feedback on how has health organizations become more health literate for senior citizens. And let me preface that with, I've been recently in a roundtable discussion where right here in Maryland, there's a community where there are simple things as you can do to help senior citizens, as far as taking them to the doctor with a note taker who can help them process information later. But I wanted the panel to really speak to how does organizations, health delivery organizations and health system, including nursing homes, really become much more health literate, or what is your experience around for the geriatric population?
That's an excellent question. I'm going to start with Dr. John, actually, because I think when you think about the organizational standpoint, I'm sure you have some insight. But from the healthcare perspective, there's also a different lens, and then from the corporate perspective. So it would be great, I think, to have each of you, if you can, speak to that.
From my experience, it seems as though it's become more complicated and more difficult. It seems like there's more hurdles, more regulations. I think that all you can do is just try to keep things as simple as possible. As the lawyers advise, document, and make sure that everything that you do can be justified in terms of what the clinical presentation is. But I do think that I don't have a sense that anything is getting easier. I have a sense that it's getting more difficult. I'd be interested in what other people's experience is.
Yeah, I appreciate your perspective, and I think that you're right, simplicity is key. The more things that we can strip out of the system to make it simple for those of the aging population, I think that is the key thing. But also from a corporate or Lilly perspective or pharmaceutical manufacturer standpoint, we have to include more patients of the aging population in our market research. So again, I was a former market researcher in my prior life at Lilly. And typically, the aging population was not incorporated into our market research as we were looking to design solutions or interventions that would ensure that those of the aging populations did receive access to medications and were receiving the interventions and programs and solutions that would help them live longer, healthier lives. So I think as a manufacturer, we do have a role to play in ensuring that that feedback is captured into the plans that we make. Also, again, working very closely with the faith-based organizations is key for us. And again, in our partnership with the Church of God in Christ and other types of organizations of that matter gets us closer to those communities so we can get that feedback and deliver solutions, deliver health care that is most meaningful for that population.
One of the things that we've done just in our experience at our offices is tried to institute care managers So Medicare is starting to cover care management fees, and that allows us to call the patients once a month and do a check-in and see if they're taking their medications. And I find that that is one of the things that is helpful in trying to navigate the healthcare landscape, which, as you said, is getting increasingly complex and confusing and difficult.
And navigation is really key. Dr.
No, I think that one of the things that I try to do is to try to simplify the landscape if I can, because let's say a person has unstable blood sugar, hypertension, arthritis in the knees, but the problem is overweight, abdominal obesity. I'm going to try to target the abdominal obesity and see if that ameliorate some of the other problems. So if you can find a patient that seems to be presenting with multiple diseases, but there's a single pillar or a few pillars holding the other diseases up, I would try to simplify things by targeting that.
I believe you were here before. Did you want to speak now?
Sure, thank you. Okay, so I'm Leslie Quander-Wooldridge. I'm a writer. I've written a lot about older adult issues, and I have a question. Trauma came up in the last panel. Also, people are repeating that you need to check in with people. You need to check in with older adults in your lives. But what do you do if you're a layperson, you're not a dentist, you're not a physician, you see that someone has a problem, they don't want to acknowledge it. They're older than you, they tell you they're fine, that kind of thing. And or you're their child and you say, Mom, I can see that you're struggling with this, and they don't want to agree. What do you tell a layperson to do if access to professional care is not an option? If you're getting, bad feedback from the person that you're trying to help, what do you advise?
Yeah, stress and anxiety sometimes are bad words in our culture, and it's certainly something that we have to take on. And then to your issue, is there one of you that want to speak to it specifically?
Well, I can speak to it in the sense that we've had a lot of people who were reluctant to seek health care, and one of the things, there were a couple of things that seemed to work. A peer-to-peer approach, because if you can find somebody that seems to be having the same problem, or a group of people that seem to be having the same problem, and have them approach the person, then they may be able to see something in that respect. So, one of the things that we were trying to do, it's always been hard to get men to go to the doctor for the most part, but we would try to get celebrity role models. Like we had James Brown for a while, and he used to do public service announcements like saying, I feel good and I want you to feel good too, so get a checkup. So the point is that if you can get somebody that the person looks up to that may be having a similar problem, then maybe that can persuade the person to do something about their problem. In terms of if you don't have assets, I know that where I am in Atlanta, there are churches that do health fairs and things like that. If you can get a person to go to a health fair and get screened, then that may be that. And again, a lot of people won't do things for themselves, but they'll do it in a group. And sometimes the approach you need to take needs to be tailored to the person's personality. If they're afraid of what they may find, try to shift the fear from finding out about it to finding out about it too late. Try to shift the fear from going to the doctor to not going to the doctor. If they pride themselves on their appearance, then you can basically say, a lady is complaining that she's getting wrinkles in her face. I'm telling her about, well, maybe you need to stop smoking. So the point. So if it's a question of that, if it's somebody who likes to be in control, you challenge them. Say, well, your blood pressure was high. What are you going to do about it? So the point is that you try to tailor it to the person. Try to figure out what is important to that person. If that person prides themselves on being responsible, you say, well, you need you to get checked out, because what are we going to do if something happens to you? So the point is, there are various approaches that you can take, because we have to deal with that male reluctance to go to the doctor all the time. I always used to say the 3 hardest things to do are run a marathon, wrestle an alligator, and get a man to go to the doctor. And I'm not sure in what order.
Very well put. Dr. Kimberley?
So you're speaking about, does the person you're talking about have a good relationship with their doctor? Okay, so if they happen to have a good relationship with their doctor, but they may not want any help from you in particular, and I'm not saying you, but just you in general, but perhaps they've allowed you to go to the doctor at one time, but a lot of times I suggest that you get the patient to sign a HIPAA release form, and you may not necessarily get information from the doctor, but I'm a narc. I tattletale all the time. So, I'll call the doctor and I'll say, hey, this is going on. Can you do this? I want you to know that I've seen this going on. And then the doctor may make a phone call to the patient and say, hey, how are you feeling about this? Or, never saying that you've called to tell anything, but, just say, how are you feeling about this? Why don't you come in and visit me? I haven't seen you in a couple of months and I want to check this out. Or, just being very coy, but, they may have such a great rapport with the patient that they're able to get the patient to come in, whereas your persuasiveness may not work, but the patient-doctor relationship may be so good that they're able to get them to come in and see them. I find that works sometimes.
Dr. Kisha, did you have anything from the patient-provider perspective?
Yeah, I think those are both good points. I mean, I've experienced this even in my own family with an uncle who, as a doctor, I could look at him and see that he was sick. And that's really hard when you're in that position that somebody isn't thriving and you want to do all that they can. And in the end, it was peers, it was other family that helped get him into the doctor. But sometimes you just have to wait till that person is ready. And that can be hard to watch. But you have to give people that autonomy to do that.
And sometimes it's not even a peer-to-peer approach. There may be somebody that they would listen to, like their minister or something like that. A trusted person may be able to approach them better than you could.
The gentleman over here.
Matthew Schick with the Association of American Medical Colleges. Our workforce projections that actually were released and updated last week are showing that due to the aging baby boomer population, we're going to be facing significant workforce shortages nationwide. And I was wondering if you could comment what those broader trends, the impact would be on the diversity of our workforce, on health equity, but then also what advice you would give our educators as they train the next generation of providers that'll be caring for that aging population.
That's an excellent question.
So currently, I think 86 cents off of the dollar spent on healthcare is due to patients that have chronic illness. And that's today's state. Now, we know that number will only get worse or go the direction in which we don't want it to go with an aging population and a population that, in some cases struggles to take their medication. So that being said, in order to move that number in the other direction, we got to make sure that people who are in an aging population that don't have healthy living lifestyles, make sure that education is there. Two, making sure that from a disease state perspective, really being able to educate on the consequences of not getting their diabetes treated. Even if you are if you're in pre-diabetes state, that is still a serious condition where you have to get treated. So speaking about that in an aging population and the caregivers that will ultimately be treating or helping those patients move forward. And then third, ensuring that there is education and awareness on the importance of staying on therapy. Again, approximately 50% of people on diabetes or any disease state struggle to stay on their medications. And we know when that occurs, the cost to not only the patient, but the system goes up. So again, you almost have a double whammy of an aging population and a population that is struggling to take their medication. So if we can deliver on those three things, I think we'll be in much better shape, but we still have a ways to go.
I think that if we have a declining workforce, then I think we need to focus more on trying to identify problems earlier when they're usually easier to treat. You can treat somebody with a water pill with high blood pressure, but it's a lot harder to treat them when they're on dialysis and renal failure because hypertension has gone untreated for such a long time. So I think identifying problems earlier would put less stress on a declining workforce. Another thing that I do right now, I'm an MD, but I'm training a graduate nurse. We need to be looking at physician extenders. What do the physicians really need to be doing, and what the physicians really need to be doing, and also, what can be handled by somebody else, or at least part of the time handled by somebody else. And I also think that I'm an assistant professor at Morehouse School of Medicine. Morehouse is focusing very heavily on primary care, and I think that maybe we need to try to steer people away from the super specialties and more into identifying the problems early and treating them when when they don't need the tertiary care, you know.
To the point of the workforce issue, you're so right. So those older physicians, clinicians, nurses are all starting to age out of the workforce, and we're not replacing them. So more African American males graduated from medical school in 1978 than are graduating in 2018. And those males who graduated in 1978 have now been in practice for 40 years, and they're starting to get out, and we're not replacing them. And we know that our minority medical students tend to care for minority communities, and as those fewer and fewer are entering those careers, we're having fewer people serving those communities, and we start to get into issues of health equity and disparities. And so, as Dr. Jean mentioned, really having those pipelining programs starting when I was in medical school, we had a program that started in elementary school to pipeline folks all the way up to medical school, identifying them that young in those communities, reaching out to the schools, the churches, and really helping to foster those kids to give them an idea of what the concept even is of becoming a physician. And so I think the program tomorrow of really getting out into the community and into the schools and educating students about what it means to be a healthcare provider and planting that seed really young, I think makes a difference in creating that workforce that we want to see, that diverse workforce that we want to see years from now.
Definitely being a part of that solution. So if you're going to Doctors Back to School and if you didn't sign up for tomorrow, definitely think about that for next year because it is an important program. And if you don't see the options, then you often don't know they're available. We'll take this question.
Thank you. I am Claudia Craig Byers. I am from the National Black Nurses Association and the University of Pittsburgh School of Nursing. Dr. John, thank you for sort of mentioning one of the things that I think of very much about the role of nursing and nurse practitioners in this field of maybe filling in that workforce gap that we have with older adults. But that's really not what I came to the microphone for. I came to the microphone to ask your opinion about I'm a geriatric nurse. And I wanted to ask your opinion about 3 things that I tell my nursing students and 3 things that I've always done in the practice of working with older adults. I'm also fortunate to come from Pennsylvania, which has the 2nd Allegheny County in Pennsylvania. And I'm told it's the 2nd oldest county as far as older population in the country. The state of Pennsylvania uses its lottery to fully support older adults. So there are 3 things that we think about and we do in Pennsylvania, and I don't know if any of you on the panel are familiar with these, but one is the Area Agency on Aging. I listened to that young lady down at the other end talk about the condition of her grandmother going into a nursing home. The Area Agency on Aging, agencies on aging, I am told are a part of a federal program that every county is to have an area agency on aging. Within that area agency on aging is there an older adult advocate. They're responsible for investigating the conditions in nursing homes so that if you have a burned out, insensitive staff at that nursing home, that advocate is to report to the State Department of Health in that state and close down the certificate for that agency or that particular home. So it's not that your older person is left at the behest of the home that you put them in. If they are substandard and not performing properly, there is a legal way to get those homes closed down or have someone come in and take over that home until it reaches the standard it's supposed to have. So what is your opinion about the Area Agency on Aging? I also tell my students, and I have also encouraged in my practice, especially to families, when you bring someone to me who's 65 years or older, and I have no disrespect for family practitioners, but I always encourage them to take that older adult to a gerontologist because they see practice and the delivery of care for that patient differently. So that even though it may be mom has been with that physician for a very long time, if I suggest that there is a doctor who does nothing except focus on the needs of older adults. So do we refer our patients who are older to a gerontologist? And thirdly, in every county, there is almost always the Department of Health from that state will have an older adult advocate who reports to the Department of Health in that state, or Commonwealth, because Pennsylvania is a Commonwealth, will report to that, always with the idea in mind that they are trying to protect these very fragile but specially classed group of people. So that I don't know if, I didn't hear this mentioned at all, and those three things mentioned at all in the panel. The area agencies on aging, sending your older adult to a gerontologist, and then contacting your State Department of Health for your older advocate.
Thank you. Those points are all true. And if you're here in the National Capital area, there are a number of options as well. There's also an ombudsman as well. I think there was a question there. Sorry, would you like to take the question?
I would agree with their points. I think that, in terms of the, gerontologist, I think having a relationship with a primary care provider who knows you and knows your family and is willing to work with you on every stage is what's ultimate and important.
Excellent.
I would also say, though, that about the question on the gerontologist, it would depend on the state of health of the elder person. There are 75-year-olds who run marathons and 25-year-olds who are not in good shape at all. So the point is that if the person has minimal health problems, they may only need a primary care practitioner, whereas if they have multiple health problems, then the gerontologist would definitely be indicated. I also think that sometimes, this is just my opinion, I think sometimes we put people in nursing homes that really could be managed at home, with visiting nurses or something like that. So I think, again, with a declining workforce and healthcare expense, I think we need to focus on conserving resources and using the big guns only when it's really needed.
Sometimes it is knowing the patient that's before you. I know that I think, are now officially about a minute over. And we didn't mention this at the beginning, but Mia, is the board for questions still an option for those that didn't get to raise their questions today? Perfect. So we'll be able to get that information to you, mia.keys@house.mail.gov, if you'd like to have an additional question. Our panel will also be to the side of the stage if you'd like to raise it. My apologies. I just want to make sure that we can move forward with the rest of the program today. I do have two housekeeping updates before we thank our panelists. One is good news. The gala was a success this year, but that also means it's sold out. And then as you exit, if you could please fill out your surveys. There will be a gentleman collecting that feedback. Many of us work in public health, and we know to improve the services, you've got to give that feedback. So I'd like to thank you all for your time. I'd like to turn our attention to thank our panelists for the insight that they've shared. And in closing, also thank Congresswoman Kelly and the CBC Health Braintrust for this wonderful conversation. Have a great afternoon.